All right, so we are live on YouTube, so I'm starting.
Okay.
I request the attention of all the faculties and delegates. Kindly allow me a few minutes of yours and let me introduce myself and the faculty members of the session. So good afternoon and welcome to one and all. This is Ankita from ClearNet, the science session assistant for a seamless experience. And ClearNet is India's most trusted and widely used digitech platform with multiple enriching services exclusively for doctors. ClearNet is very proud to be a digital partner for this webinar named Panel Discussion Neonatal Hyperbilirubinemia and organized by National Neonatology Forum, GUJRT. Let's begin today's session, for which I would like to invite Dr. Kunal sir to take over. Over to you, sir. Kindly proceed with your talk.
Thank you, Ankita. So, welcome one and all. So, today we'll be discussing about the hyperbilirubinemia, which we have been discussing since past two talks, and we'll continue with that. But this time we'll be having a panel discussion. I will request Shwetal ma'am who is our president of Gujarat State NNF, to say a few words, and then I will introduce Dr. Vishal, and he will continue with further things.
Thank you so much, Kunal. I welcome all the panelists and Sheila ma'am, Pooja, and Dr. Prakash. We already did a guidelines with the expert session. Now, today we are having a case-based discussion, so it will be more practically implementable of yours. I thank all the panelists and I hand over to Vishal.
So just I will first introduce Dr. Vishal.
Vishal?
Yes, I'm here. Yeah.
Okay. So today for our panel, we have a moderator, our eminent faculty, Dr. Vishal Goel, who has done his fellowship in neonatology from Royal College of Pediatrics, Child Health, UK. He is a visiting fellow in neonatal ECMO series at Leicester, UK, and presently is consultant neonatologist at Urban Newborn Care Center, Ahmedabad. Welcome, Dr. Vishal, and I would request you to kindly proceed with the panel discussion.
Yeah. Should I share my screen first?
Yeah, sure.
Yeah.
You can share it. Yeah.
Which one I need to...
Green button is there below. Share screen. Yes.
Can you see here?
Yes. Do you have to select? Yeah. You have to. Yes.
Okay. So first of all, I would like to thank Dr. Shwetal ma'am and Kunal and all the advisory committee from the NNF Gujarat to inviting us to do this discussion. Before I start the discussion, I would like to introduce our panelists. So our first panelist is Dr. Sheila Iyer, madam. I think she does not need any introduction. I think she spent her whole life in the Baroda, starting from MBBS student, followed by post-graduation, followed by AP, associate professor, followed by she went to the Australia to train in the neonatology and came back and headed the SSC department of pediatric such a long time. And she is one of the teachers of the teachers. And our current president, Dr. Shwetal madam, is also her student. And including all my colleagues from the Arpan, I think, except me, all are trained under her, including Ashish Mehta. So I welcome you, ma'am. So if I say if students are so good, obviously teachers has to be best. Welcome, Dr. Shwetal madam. Now our next panelist is Dr. Prakash Waghela. He is a consultant neonatologist in the Bhavnagar. He's one of the senior consultant neonatologists, I would like to say, is in the Bhavnagar and director of the Nice Children Hospital. He is also running the PG fellowship in neonatology, NNF fellowship, and his area of interest intake survival of EW and non-invasive ventilation. He has a multiple publication in international as well as national journal. So I welcome Dr. Prakash Waghela. Our third panelist, Dr. Pooja Patel. She did her MBBS and MD Pediatric from the Baroda Medical College SSC Hospital. She did her fellowship in neonatology from Babylon Hospital, Jaipur. And she is an executive committee member of Academic of Pediatrics Baroda 2022. And currently she is a treasurer in same place in 2023. She conducted multiple basic NRP course, workshop. She also working as an assistant professor NICU in charge in Dheeraj Hospital, Sumandi. So I welcome Dr. Pooja Patel. So now let's take the discussion one by one. So basically why we are discussing this one, because the last update from the American of Pediatrics is in 2004, followed by they update the guideline in 2009, and plus UK also released the new guideline. Followed by we have also our NNF update in 2014 and 2020. And now the American Academy of Pediatrics come with the new guideline. So we'll see this practical concern in this case-based discussion. So in this first case, we have baby XY, 38 plus 4 weeks, mother blood group not known, normal antenatal as well as antenatal scan and the period, birth weight 3.2 kg, male. The baby came to the OPD on 72 hours of the life, and we can see the jaundice up to the chest. Baby is on the exclusive breastfeeding and current weight showing around 2.946 kg, with ultimately 250 gram, 54 gram weight loss. When we did the transcutaneous bilirubin, it was 14.2 milligram per deciliter. If we talk about the risk factor, we haven't know the risk factor because we could not have any blood group from the mother side. So I will ask the first question to Sheila madam. How will you approach if maternal antibody screen is not unknown, maternal antibody screen unknown? Over to you, ma'am.
Ma'am, you are muted.
Yeah. Now, am I audible?
Yes, ma'am.
Okay. This being a full term, 38 plus 4 weeks, probably a normal baby, discharge at 48 hours. We do not know the discharge TCB. Has come with 14.2 milligram. Risk factors are unknown. How was the TCB taken in OPD is important, because TCB, the site where you take, is also very, very important. If it's been taken at, say, thigh or lower groin, but your intensity was much higher in the upper part, there is documented difference noted. So this is something which we need to teach our PGs who keep doing TCB immediately and then putting it. As I don't know the pre-discharge TCB and the increase, and mothers, this is not known. Still, this is between the 3 to 5 days when benign neonatal hyperbilirubinemia is very common. More than 80% of the babies would develop jaundice around this time. So how is the feeding? Adequacy of feeding, which is to be checked. Mother's blood group should be known, because these days it is a mandatory thing on their antenatal card that what was mother's blood group. So you start with that maternal antibody screen, okay, is not done. But if mother's group is known, and I know she is positive, she is not O, neither O group, and not a male baby, not coming from a high risk zone of G6PD, previous baby not having hyperbilirubinemia, no family history significant, then I might just examine the baby for overall activity and everything. If there is anything which tells me that TCB needs to be confirmed with TSB, always remember TCB nearer to phototherapy zone for the age in hours. One needs to confirm. And if nearer to phototherapy, start phototherapy and send investigations. So probably this looks like what earlier was called as physiological jaundice, what now is named as benign neonatal hyperbilirubinemia, but it's a diagnosis of exclusion. So you need to check mother's blood group. If mother's antibody screen you said is not done, then I need to check the baby's group, and if possible, take a DAT as soon as possible. DAT is positive, no, it's negative, then we need to look at all other things and just do the counseling and follow-up.
Yeah, thank you, ma'am. So as madam says, if we could not know the maternal antibody screen, and if you feel that baby has a high jaundice level, then according to the new chart, we have to send or we should send the blood, at least baby blood group, and follow by the direct antibody test. So now my next question to Dr.
Vishal,
Prakash.
at this juncture, I would say people living in periphery may not have DAT done.
Okay, so at least blood group.
Yes,
Yeah.
that's why we need to talk about that mother and baby's blood group.
Blood group, yeah.
Because DAT, only certain blood banks and some labs only would do it. And at peripheral centers, that's not going to be. And I would feel that a healthy feeding well baby who is 3.2 kg, passing adequately urine, if you know mother baby's blood group and the baby can be monitored, then it not transfer just for DAT to a higher center.
Now, my next question to Dr. Prakash Waghela. What do you mean by hyperbilirubinemia risk factor and hyperbilirubinemia neurotoxicity risk factor? As we know, in this case, risk factor we could not know. Over to you, Dr. Prakash.
Yeah. Good afternoon.
Good afternoon.
We know in the hyperbilirubinemia, the gestational age, whenever the lower gestational age, whenever the gestational age is less than 40 weeks, then it is a risk factor for developing the hyperbilirubinemia. Second is if the jaundice develop within a first 24 hours, that's always pathological. If the pre-discharge transcutaneous bilirubin or total cellular bilirubin, if close to the phototherapy threshold, or some maybe mother blood group may be Rh positive, Rh negative, or mother is O positive, means isoimmune hemolysis, then we consider it is a hyperbilirubinemia risk factors, or either the baby may be some enzyme deficiency like the G6PD pyruvate kinase deficiency is there, or if the rapid rise of the transcutaneous or the total serum bilirubin in first 24 hour more than 0.3 milligram per hour, or after 24 hour 0.2 milligram per hour, that we consider as a hyperbilirubinemia risk factor. Simply if the mother is Rh negative or O positive, then we have to do the cord blood, the baby's grouping, whether it is Rh positive or not. And if the jaundice is visible within a 24 hours, it's a risk factor for the hyperbilirubinemia. Now the certain factors like they are predisposing for the neurotoxicity, like the hyperbilirubinemia neurotoxicity. It's considered as a lower gestational age. We have to check the albumin level. If albumin level is less than 3 gram per deciliter, or if we have mentioned the previous factors like if the isoimmune hemolytic disease like the mother ICT is positive, baby's disease is positive, G6PD deficiency, and other factors like the sepsis is there, acidosis is there, asphyxia is there, and an unstable condition, they are the risk factor for the neurotoxicity, because they will disturb the blood-brain barrier and the bilirubin will cross the blood-brain barrier and damage to the brain.
So rightly said by Dr. Prakash, the difference between the hyperbil risk factor plus a neurotoxicity risk factor. So now it comes to a picture like if baby is excessive breastfeeding and feeding well, there is not that much weight loss. Then what's the difference between breastfeeding jaundice and breast milk jaundice? Over to you, Dr. Pooja.
Good afternoon, all. Now, in this case, everything is day of life 3, and child has already lost weight of around 254 grams, right? And the child is weighing around 3.2, which is currently around 7 to 8% of weight loss is there. Now, breastfeeding jaundice is most common in this child, since in many cases we have seen, like in case of exclusive, like in case of LSCS baby who had undergone, mother who had undergone LSCS, the initial days where feeding is not adequate. So in that case, what happened? Child is sucking well, but child is taking a very suboptimal amount of feed, and we have weight loss slightly more than expected. Okay, so in that case, the enterohepatic circulation is not well developed. So in that case, the child will start developing jaundice, but it's a benign condition. Once the feeding will be established better, then the jaundice will resolve on its own. Maximum it will take a week or 10 days, not more than that. But in case of a breast milk jaundice, uh, the real cause is still unknown. There are few possible theories because of which breast milk jaundice occurs. It usually starts after 4-5 days of life, and the most current theory is because there is increase in free fatty acids in breast milk, which displaces bilirubin from the albumin, leading to hyperbilirubinemia. Some theories are there where there is, there is action of beta glucuronidase, or that breast milk contains high amount of epidermal growth factors, which leads to increased absorption of bilirubin and decreased excretion from the intestine. Other theories including interleukins 1 beta, UGT activity decreasing. We have seen all those theories, we have heard about it, but there is no short cause for that. But in breast milk jaundice, actually it stays for a longer period of time. It is also one of the cause for a persistent jaundice staying more than 2 weeks, 3 weeks in infant. But we don't need to stop breast milk in that case. We just have to ensure a proper breastfeeding. If baby is feeding well, baby is gaining weight well, then jaundice will disappear on its own in few days or a few weeks.
Yeah, so rightly said by Dr. Pooja that breastfeeding jaundice generally appear around 3 to 5 days of the age because of the inadequate feeding, and breast milk jaundice generally appear as a prolonged jaundice after 3 to 4 weeks. But in that case, the baby has adequate weight gain and adequate growth. Okay. So my next question to again Dr. Prakash Waghela, sir. So how will you approach this baby? And when will you do the total serum bilirubin based on the transcutaneous bilirubin?
Okay, this baby is the after 72 hours is the bilirubin is 14. So according to this, we have to chart the chart that we have to use. That is the specific our specific charts and gestational age specific charts. We have to plot the transcutaneous or total serum bilirubin according to these charts. If it is a near the phototherapy zone, then we have to do the phototherapy. If it is below the phototherapy zone, then we have to ask the patient to keep in the close follow-up. So
okay.
just
so in this case we couldn't know the risk factor. So as per new guideline, we plotted on the phototherapy threshold with the neurotoxicity risk factor. And if we know that the TCB is around 14 and at the 72 hours of the age, and if you see the 38 weeks, the cutoff is around 16.6. So as per guideline, if your TCB is within the range of within a 3 milligram per deciliter of the range, we have to look for the total serum bilirubin. Or either if you found the total serum bilirubin more than 50, we need to look for the total serum bilirubin. So now we got the result now. So if you see mother blood group is A positive, so whatever the baby group doesn't matter. Direct antibody test is negative, and total serum bilirubin is 16.4 milligram. Am I right? So if we plot again, the chart is changed. Now you can see that there is no any risk factor. So we need to change the chart. And if we see the cutoff at 72 hours of the life, it is around, around 21 point something. And now we got 16 only. So this baby have far below the phototherapy range. But also it is important to follow up this baby. So I would like to ask Dr. Pooja, how will you follow up this baby?
Okay, so now we have seen that the total serum bilirubin of this baby is around 16 milligram per deciliter, which is approximately, if you see the difference, the cutoff or the threshold value lies around 2021, and the total serum bilirubin is 16. So what we'll do, we will minus this total serum bilirubin from the threshold, and we'll find the difference. Okay, so AAP has given a beautiful discharge recommendations. So if your difference comes around 4 to 5, okay. So when your difference is coming around 4 to 5, regardless of age or any discharge time, we do not need to give phototherapy, but what we need to observe the child clinically. We need to ensure feeding properly in this child. And if required, we need to do total serum bilirubin or transcutaneous bilirubinometer in 24 to 48 hours. Okay.
Perfect. Yeah, thank you. So I think Dr. Sheila Madam already or Prakash sir already answered this question. When will you say the rapid rate of increase? So any baby, if you see on the follow-up, if baby is more than 24 hours, if your bilirubin increase 0.2 milligram per deciliter per hour, means 5 milligram per deciliter every 24, that means you can see the rapid rise of increase. Or if it is baby is less than 24 hour, and if your rising rate is 0.3 milligram per deciliter per hour, then you need to, in that case, we can call as a rapid rate of increase. If so, in this case, why it is a terminology rapid rate of increase? We need to rule out the hemolysis. Okay, so if you baby does not have any direct antibody test, we need to request this parameter to rule out the hemolysis. So now we'll heading towards our case 2.
Yeah,
This
before that,
is
Vishal, I would just say that all
yeah,
those who are using TCB, it should be well
Hmm.
calibrated.
Yeah, definitely.
Yes, and with your TCB and TSB difference is coming more, then there definitely, because gold standard is TSB, especially with diazo method.
Yeah, the gold method,
So,
gold standard is TSB only. Yes.
okay, with different machines properly done or not, like here it was 2, which is acceptable. Your 14.5
Yes.
and 16. Again, the difference is higher in pigmented babies as compared to Caucasian.
Yeah.
So everybody, it is not synonymous, or you can use TSB and TCB same way. So people should be aware about the difference and
When to do the total cellular bilirubin.
yeah, and take the decision on TSB. TCB, yes, has come high, you can start the therapy immediately.
Yeah.
But beyond 16, it has a big margin of error. And then you have to do it only your TSB.
Yeah. So this is another case we have. This is a baby XY, O positive mother, 37 weeks of gestational age, normal antenatal period and scan, elective LSCS, baby deliver well, no resuscitation required at the time of birth. The date of birth is 7 January 2024. Birth weight was 3.04, male, and baby blood group is A positive. So we did at the time of cord blood. This baby came directly on day 5. Once 96 hours are completed in the follow-up, the baby's weight is 2.6 kg at that time. Baby is on the excessive breastfeeding. There is a jaundice up to the abdomen, and when we did the total, transcutaneous bilirubin, it was 16.5 milligram per deciliter. If we talk about the risk factor, the gestational age is less than 38 weeks and with the ABO incompatibility. So over to you, Sheila madam. How will you approach this baby?
Okay. One thing, this baby is just at borderline 37. Feeding issues could be there.
Yeah.
And what was the birth weight?
3.04.
So you already have 13%
44.
weight loss.
Yeah.
And late preterm and this 37 weekers always have latching issues and feeding difficulty. So that's one more added risk factor, because more dehydrated you are, your bilirubin will go up. Whether the first baby also she's priming?
Yes, it's priming. I forgot to mention this is priming.
Yeah, because otherwise the previous baby also having ABO incompatibility and jaundice requiring therapy would add on to one more risk factor. And we need to look at the chart. One more thing, because we have feeding issues and the child is this. And so this would come with risk factor 38 week, less than 38 week. And
so yes, ma'am, go ahead.
I would send the TSB in this child.
Yeah. So we got the yeah. Yes, ma'am. So now TSB we got, this is a real case actually. This is a 22.8 at 11 January at 1 p.m.
Okay. And what was the difference time between TCB and TSB?
Is around 2 hours maybe.
Okay. So it was not the TCB done at some other hospital.
Yeah. And we have a machine which actually measure only ear TCB. Okay. So it is not like the Billy Chat one, the original one. So okay. That might be the difference.
Yeah. And so now the bilirubin is 22.8. And in such cases, you have already proven that the G6PD was normal. That was not the cause. Now, if we look at the chart, where are we? We are almost nearer to your exchange.
Yeah.
Okay.
So it is just below 0.2.
Yes, yes. Now you would go for escalated care actually here with the risk factors, the child already nearing the exchange zone. You would start intensive phototherapy and send investigations to look at the bilirubin albumin ratio, look at the rising, and one thing to give intensive phototherapy, keeping
Yes.
distance between the baby and the unit into 10 to 15 centimeter only. And meantime, you are awaiting all your reports. And at the same time, probably this is the baby where you should start making arrangement for your exchange transfusion too. And you
Yes.
hydrate the baby well.
Yes.
So either give the extra feed, or in case baby has any signs of sickness, you may use intravenous hydration.
So
Because in
rightly said.
summertime in our country, we see many babies coming with 20% weight loss. Bilirubin is high, and hydration helps a lot in decreasing the bilirubin level.
So as Sheila madam discussed the escalation care. So this is also new terminology in the new guideline. So when you get the TCB, within a 2 milligram per deciliter of the exchange rate, we need to start this approach. And as per rightly said by madam, that we need to, if baby is in the periphery, we need to send to the referral center who has a facility of the exchange transfusion. We have to start the intensive phototherapy with IV hydration during the transfer. If you have a facility of the exchange transfusion, we have to send some investigation including albumin, TSB and blood group cross match. We need to notify the blood bank to prepare for the exchange transfusion, and we need to measure the TSB every 2 hourly until it reach below the 2 milligram of deciliter of the exchange transfusion. So in this case, we have a 22.8 and our exchange range was 23. So until it reaches to the 21 milligram per deciliter, in this case, we have to do a bilirubin every 2 hours. Okay. So
one more thing, to a periphery centers, maternal blood samples to be sent.
Maternal blood should be sent, and we need to look for the IVIG therapy. Any point of time, if you feel that baby has a signs of acute bilirubin encephalopathy, we have to do urgent exchange transfusion. Or either if you get the TSB, total serum bilirubin, above the exchange rate, we have to do the exchange transfusion. Until it's reached, in this case like less than 21, we have to keep doing intensive phototherapy, keep hydrating the baby and repeat the bilirubin. So we started IV fluid. We did the repeat bilirubin after I think we did in 4 hours because it's not feasible every 2 hours. So it was like 20, and followed by after 6 hours. If you see that there is a 12th January 8 a.m. and the previous documented report is around 11 January 13. So after 12 hours, it reached to the 16 milligram of 3.3. So it is a below now phototherapy range. So I would like to ask Dr. Prakash sir, then when will you stop the phototherapy? When will you stop the phototherapy and when will you repeat or look for the rebound total serum bilirubin? Over to you, Dr. Prakash.
Is he cut off? Somewhere
Dr.
lost.
Dr. Pooja, can you take this question for me? When by the time we just talk with the Prakash.
Yeah, sure. Okay. So now the escalation of care, which has been introduced by Academia or American Academy of Pediatrics in the recent guidelines, they have mentioned that while giving intensive phototherapy during this care, we need to repeat total serum bilirubin every 2 hourly. Okay. And we can stop phototherapy when the 2 milligram for that our specific normogram. Okay, so we can stop that, but we have to make sure, because this child comes in neurotoxicity risk factor, so we need to check for rebound hyperbilirubinemia also in this case. And since this case is very high risk, like child may be having hemolytic disease, So we need to check the rebound. We need to check for rebound hyperbilirubinemia at least 6 to 12 hourly in this case. As early as possible, we need to see. If there is a no risk factor, we can at least wait for 12 to 24 hours also to check. But for this particular case, we need to check it at least 4 to 6 hourly. At least after 4 to 6 hourly of stopping of phototherapy, we need to check.
Yeah. So rightly said by Dr. Pooja, if your baby has a phototherapy less than 48 hours of the life, if your baby has a isoimmune hemolytic disease or G6PD, or in that case, we have to do a rebound bilirubin within a 6 to 12 hours of the life. In rest of the case, we can repeat around 12 to 24 hours of the life. There's also one question which I haven't mentioned. Should we do the TCB
No,
See, the
preferably not.
Okay.
Phototherapy treatment will hinder with the TCB result. So it is always advisable to do TCB only after stopping of phototherapy for at least of 24 hours. Then only we will, yeah.
So we can do after 24, am I right?
Yeah, we
Yeah,
can
one
do
more
after
thing.
24.
Yeah, here if we have suspected this to be hemolytic, whether your DAT was positive or not, whether your retic was high or your hemoglobin is dropping down, are also important things before you discharge them. Because these are the babies who can come with severe anemia later. So one needs to keep that in mind. Though we have handled the neurotoxicity due to bilirubin, we may land in anemia later. So that's also an important thing that we need to monitor.
Madam already answered my next question, but that would be fine. Thank you so much. So if we plot the whole case on the chart, on the right side you can see the extent transfusion threshold with the risk factor. Initial it was around 22.8. I think if we follow the proper escalation plan, you can see that this baby reaches the safe zone within a 24 hour. So now we are heading toward our case 3. This is a baby access, B negative mother, 36 plus 4 weeks of the gestation age. Antenatal period show the mother has ICT positive. The scan show mild oligohydramnios, no evidence of hydrops or fetal anemia. The last scan was done around 33 weeks of the age. Baby was delivered via LSCS. No resuscitation required. The baby's birth is around 14th December 2023. Birth weight was 2.8 kg, female. And if we talk about the risk factor, again this baby is less than 38 weeks, means late preterm and RH incompatibility. So now I would ask Dr. Pooja. I don't know, the Dr. Prakash is here or not?
Yes,
Dr.
yes.
Prakash. Yeah, so I will ask Dr. Prakash, how will you approach this baby?
Okay, there is a risk factor for the both. There is a risk factor for the hyperbilirubinemia and the risk factor for the neurotoxicity also. So we have to this baby is the around 36 weeks, 36 plus 4 weeks is there. So we have to do the baby blood groups. We have to go for the baby's direct home test and the complete blood count, CBC. We have to check for the hemoglobin is there and the total serum bilirubin is there. So we have to investigate and the serum albumin also. For
so in this case, doctors, we have to admit this baby because considering the ICD is positive, or should we wait for the admission? What we want in this case?
Is this a cord blood or after birth? How many hours? Or a cord blood?
This is this is not cord, but we admit this baby and immediately 30 minutes of the admission when we insert the umbilical line.
It is a little more than cord blood.
Yeah.
I mean, the hemolysis would have been progressing further.
Yeah. So this is a report over here. If you see, the bilirubin level is 13.6 and the hemoglobin is 8.5. Reticulocyte count is 24 and DCT is positive, like undiluted, like +4. So baby has really active hemolysis. And if we plot on this chart, it is just above the extent transfusion. So I would like to ask Dr. Prakash, should we do the extent or should we give the IVIG and wait?
Yeah, this is the hemolysis is severe. So we will like to go to the first exchange transfusions followed by the IVIG.
Okay. So if some yes.
I agree that we are going by bilirubin, but your hemoglobin is also of very severe anemia. So
Yeah.
at times for anemia also you need to do exchange.
Yeah, because
Even
yeah, so I would like to address what the role of the IVIG if you have a RH incompatibility or isoimmune hemolytic anemia. What would be the role? Does it prevent the exchange, or should we spend that much money?
Yes, that is the definitely if the IVIG can definitely prevent the exchange transfusions, but if we have to check the threshold, if we have to start the intensive phototherapy, hydration, if still the bilirubin is not coming down, then we can give the IVIG, and then in spite of the IVIG, if the hemolysis or bilirubin is rising, then we can go for the exchange.
So for example, if suppose this baby has like a bilirubin around 12 and hemoglobin is reasonably okay, 11, should we do exchange or should we give the IVIG then?
Or if it is below the threshold of the exchange transfusions, we will give first IVIG, intensive phototherapy, and we wait. We check after the 2 hours of then if the total serum bilirubin is coming down, then we should wait for the
exchange transfusion. Okay. Okay, so in this case, the exchange rate, baby already reached the exchange rate, baby already have a active hemolysis, low hemoglobin. So we did this exchange. And so now my next question to Dr. Pooja, how frequent we need to repeat the bilirubin? And do we need to do any extra precaution during care of this baby?
So, since we have, exchange has been done in this child, and if IVIG has been given, so baby must be undergoing intensive phototherapy during this time. We won't stop the phototherapy even after the exchange. So during this time, again, we have to do total serum bilirubin at least every 2 hourly initially. And then if the bilirubin starts falling, we can increase the duration of the total serum bilirubin test. Okay, but once while doing, since it's a hemolytic process, and we know that exchange doesn't do 100% exchange of the blood, exchange transfusion. So the hemolytic process, if it's a severe, because DCT was +4, the child may have a chance for a repeat exchange also. So we again need to plot every total serum bilirubin report on our specific normogram of exchange. And if it's again exceeding towards exchange value, then again we have to consider a repeat dose of IVIG, I suppose. We can give it after 12 hours, and again we can monitor baby in that case.
Okay.
Vishal, though we said we should do immediate exchange, even in best of the setup, after you have diagnosed, you at least need around 3 to 4 hours or 2 hours before your blood, which is cross-matched, and a PCV. So what was your pre-exchange? That is important. And this is how many hours post-exchange?
Yeah. So now in this case, we already know the baby antenatally. So we already prepare, because in the baby is delivered in the private setting. We know that ICT is positive. So you already requested blood for them, and each and every blood bank has exchange blood. And this baby, when we receive this baby, we already have a blood in our hand actually. So we did the exchange. And if you see the report, the reported time was around sorry, is this
previous one?
Reported time? Yeah, so it is a 1 o'clock, around 2 o'clock. So we sent around 12:30, because I think it will take some time, at least 1.5 hours to run all the reports. We got the bilirubin within a half an hour, so we know that our exchange range is already crossed. So we did the exchange like around 1 o'clock, and we repeat the bilirubin around 6 o'clock after 4 hours after intensive phototherapy. We also top up the blood actually. We know that baby is anemic, and we also make sure that baby is getting the blood around 40% of the hematocrit. So after that, the bilirubin is around 12, and we repeat again after 6 hours in the night time. You can see it is 2 o'clock, so it is again 12.4. So still I think this much exchange replace only 60% of the blood, I think. and we gave the intensive phototherapy. Still, baby has a static bilirubin, so still there is a active hemolysis is going on. So again, I would like to ask Sila madam. Already we answered this question. Any role of the repeat IVIG or albumin, or when will you do a repeat exchange or IVIG?
This child this is around 6 hours. Where does it fall on your chart?
Yeah, so it fall around. Yeah, this is the second one at 12 hours. So it is no,
Almost
sorry. This
again at the
yeah. So almost like I haven't plotted over here because I just put it on detail in the bilirubin. So it is the second one is 12.4. So it is like below the line, like below the exchange
it is
line.
below the line for 36 weeks.
Yeah,
Isn't it?
yeah,
It's 36 weeks. Again,
yeah.
it is not increasing by 0.3 milligram per kg, 0.3 milligram per
Perfect,
hour. Okay.
perfect, ma'am.
Probably a role of IVIG because you took immediately exchange. You would not have given IVIG at that point. So
Yeah.
because you
So
took immediate exchange.
yeah.
So
So
you could give one more thing, look at
there.
the albumin also and give IVIG.
Yeah. Yes. So I forgot to mention the albumin is around 2.8 actually, just borderline. I haven't a report over here. The second thing I would like to ask Dr. Sheila madam that how frequent we repeat, because the new guidelines suggesting you can repeat every 12 hourly if it is rising. But if it is not rising that much, like 0.3 milligram per deciliter per hour, should we again repeat or should we wait for the
If you're
IVIG?
not, yeah, what I would say is immediate exchange was going to be done. So you might not have had the time to give it over 2 hours IVIG. So if you're not given the first shot, you should give. Otherwise, I think if my hemolytic is high and further anemia to be prevented, I would give IVIG 1 dose at least.
Okay. Thank you.
There is
So,
a lot of controversy regarding IVIG, but
yeah, because even in the app means 2022 guideline, they suggest that it's a low evidence proof that it prevent the exchange. So that's why it is dilemma. And in our NNF in 2020, they haven't, they already said that we should not give the IVIG because their benefit is not that much adequate as compared to in all the trial. So it is still depends on the NIC
and the
protocol.
cost also is quite high.
Yeah, well, high. So
that
it is yeah. So but the moral of the story is if baby cross the bilirubin more than means exchange range, we have to do the exchange. Don't wait for the IVIG. That's the key thing. So
Again,
after
IVIG, you will give it over a period of 2 hours. You can't
2
wait
hours,
for the
yeah,
first time.
yeah. So
But
at
for
last
some reason, like you were looking for AB negative blood and it is not coming. It's taking time because you had a last minute call. Maybe it is justifiable to give IVIG.
Yeah, definitely.
So it's a clinician's call.
Yeah, it is definitely a clinician call. So in
But
this baby
can I
require
can I make a point? Yeah. So here we actually know that mother's ICT is already positive. Okay. So and plus the scan was done at 33 weeks, while the child I think was born at 36 weeks. So
Yeah,
you
so
need to know the recent scan also, and if you know that mother is B negative and ICT is positive, and if the recent scan is showing any like Doppler abnormalities, then I
NCB
think it is
studies
always
recently.
better to.
yeah,
Well, I think
to
when I was
doctor
resident, yeah, when I was a resident under care of Dr. Sheila Iyer ma'am in baby room, we had such case where the child was preterm around 34 week, and the blood and ICT of mother was strongly positive. So we overnight had actually prepared O negative blood, ma'am. And as soon as the baby was born, we immediately sent the samples, and the exchange was started, I think, on the third hour of life. Yeah.
Yeah. So in this case, I think you are rightly said, Dr. Pooja, that this baby does not have show the sign of the fetal anemia at 33 weeks of the age. And we have also thoroughly discussed with our gynec team. And unfortunately, the mom is came with active, labor pain and leaking, and they could not have to time to do the Dopplers and things. So basically, how do you diagnose the fetal anemia? For the knowledge, if your MCA Doppler flow like peak systolic velocity is more than 1.5 persistent, that means baby might have a fetal anemia. Or in the low risk baby, if the fetal Doppler showing the MCF low peak systolic velocity more than 1.8 in low risk baby suggests of a fetal anemia. So this is the parameter we need to look into before the delivery. But unfortunately, in this case, it is so much die hard. This baby mother came to our setup, I think around 34 weeks. Once baby has a 33 weeks, and so we know that this baby is going to be delivered at any point of time. And fortunately, they carry forward till 37 weeks. Now baby is fine, and this baby require at least I think 96 hours of the phototherapy, and her last bilirubin was around 14 and hemoglobin is around 15. So if I plot over here, if you see this is an exchange chart from the birth at 6 day, it is far below the exchange range. If I plot on the phototherapy neurotoxicity risk factor chart, this is the bilirubin which we done. There is also one or two in between that, but it's difficult to put the dots over here. So at last, this is the point where we stop the phototherapy, and after that one, we have in between there is a one which is also like almost same, but after 24 hours, the rebound bilirubin was like far below the line. Like in this case, 36 weeks, so it is around 4 milligram per deciliter below the threshold. So now I would like to ask Dr. Prakash, how will you follow up this baby? And any supplements or any counseling do you want to do in this case?
Okay, just we have discussed earlier, we have to keep the close follow-ups. Means before this is the high risk baby, so we have to check the total serum bilirubin after the 4 to 6 hours of the stopping the phototherapy or action transfusion is there. Right.
Yeah, so in this I would like to say another thing, like Shilaman rightly said, that this baby might get the anemia, and baby might this baby require at least follow up at least 3 months of the life till 3 to 4, because your antibody will be stay around 45 days to 60 days, because one vaccine only replace the 60% of the blood, so still baby has that much antibody. So maybe might came with your in your OPD with the anemia, not with the jaundice sometime. So if any point of time, if your hemoglobin went down below the threshold, sometime we need to transfuse the baby. So that's a thing we need to tell the parents. Otherwise, parents will not aware of this thing, and maybe might end up with the congestive cardiac failure or maybe poor mortality.
I think I recently encountered one such case. Another thing I would like to point out here, your bilirubin may not be high, but because of the biliary sludging, you might start getting high direct bilirubin. When there is acute severe hemolysis, biliary sludging does occur. So post 1 week, you may have increasing direct bilirubin with anemia.
Yeah, definitely. So now our next case is last case. This is a baby XX B positive mother, 29 weeks of the gestation. So this is a preterm baby. Normal antenatal period and scan is also normal. Antenatal corticosteroid given, not in Ahmedabad, but is the periphery. Baby was delivered in emergency CS for preterm labor pain. Treated for the RDS, PDS, sepsis, and preterm care. Referred to Urban Newborn Care Center on 25th day of life for NEC. When we received this baby already had a perforation. So baby was operated, ileostomy was given, feed was restarted after 7 post of day. I think he took around 18 days to reach the full feed because of the intermittent abdominal fullness or vomiting. So during that period, baby was on the full TPN. We generally used to do the nutritional every 7 to 10 days, and it showed that total serum bilirubin was 4.6, conjugated bilirubin around 2.4 milligram per deciliter. Septic screen was negative, urine color is normal, stool yellow greenish, and adequate weight gain. So my question to Dr. Pooja, what would be the differential diagnosis, and what investigation would you like to do in this case?
Okay. So this baby has developed jaundice and that too a conjugated hyperbilirubinemia later in life. Okay, so the physiological jaundice chances are very less in this case. Now, baby was on full TPN, so my first diagnosis would be a TPN induced conjugated hyperbilirubinemia. The second would be, since the child was kept NBM for a long period of time and feed wasn't been introduced. So my second could be, I think, breastfeeding jaundice also, but it's very uncommon, and could be breast milk jaundice also. It is also a case of prolonged hyperbilirubinemia. I would like to get then TSH of this baby to look out for the hypothyroidism. Child initially was septic, so because of the sludging also conjugated hyperbilirubinemia could have occurred. And lastly, the metabolic like Crigler-Najjar or any Gilbert syndrome, that I would like to get done. I'd like to see for the septic screen as well as TSH in this baby. Also would like to get then at least DCT, direct antibody test of this baby to approach this baby, whether to consider or not. And since it's an conjugated bilirubin level are more than one, the recent guideline says that if a direct bilirubin is more than one, we need to consider as conjugated hyperbilirubinemia. Initial, it was like if the bilirubin was more than 50% of the total bilirubin, that has been excluded now. So this is a conjugated hyperbilirubinemia where your phototherapy or any intervention won't work. We just have to treat the cause in that case.
So in this case,
Should I-
right? Yes, ma'am.
Should I add? Okay, let the further discussion go, then I'll speak.
Yeah. So as rightly said by Dr. Pooja, that if any point of time, if your bilirubin is conjugated bilirubin is more than one, according to new guideline, we have to do the rule out this much causes for the direct bilirubinemia. And we did the TSH in this case, so it was like 52.21, so it is slightly high, so maybe have a hypothyroidism. Thus the thing is, most of time when you treat the NEC baby or operated case, generally we presume that baby has a TPN induced jaundice. And in this case, I think any case who have a like this kind of direct bilirubinemia, before jump into the diagnosis like TPN induced, we have to rule out certain condition like most commonly hypothyroidism case. So I think Dr. Pooja already told the cutoff for the prolonged jaundice. You need to screen if you find the jaundice more than 2 weeks of the age in term baby and more than 3 weeks of the preterm baby. And rightly said by Dr. Pooja that direct bilirubin more than one is considered as a abnormal. So in this case, we gave the hypothyroidism supplements, thyroxine for I think 2-3 months. Initially, the TSH was still high, like 56, 70, then went down to 40. But after 4 months, we got a normal TSH like 0.88. And if you see the total bilirubin, it went down automatically from 2.4 to 0.16. So I think this was the discussion, and I would like to ask all the faculty, all the panelists to give at least one take-home message regarding the hyperbilirubinemia. Over to you, Dr. Sheila Madam.
Acha, before I go to the message with the previous case, I will just go back to your DD slide. Whenever you have a direct component more than 10% or more than one, your Crigler-Najjar and Gilbert go out, because the basic
that's why I mentioned
conjugation is the defective thing. So that would not come. Infection remains, especially because this child had NEC and went through lot of things. Yes, your screen was negative, plus culture must have come. Breast milk jaundice, again, the direct component doesn't increase. It's the indirect unconjugated. So in priority, it would go lower down as compared to this. Hypothyroidism, really you had very high. Otherwise, one has to remember preterm, your TSH are different.
Yeah, definitely. So and I would like to add one more thing in this case, like particularly if you're talking about infection, don't think about the bacteria only, because we transfuse the baby, this much baby at least 1 or 2 times during the surgery. CMV is positive. So we got the few cases in last year that baby has a direct component and when we screen for the CMV, urine PCR, that was positive. So
Yeah.
when you think about the infection, if your bacterial culture is negative, just rule out a viral one.
Okay,
So it is
probably
better.
looking at the enzymes would have been a good idea.
Good
So
idea.
that like galactosemia and other things are coming
Other
up
things.
also, you would
Yeah.
know.
Yeah.
So along with
And
direct looking at the enzymes, because your stool was not all that clay colored or
like yeah.
whitish. So it was not going into a important cholestatic findings. It was more towards a hepatic involvement. And one more thing, in the first case, why did you get a TSH done at just at 72 hours as a part of metabolic screen?
Because in this case, I think as per guideline.
No, not in this. This is justifiable. The one at 72 hours, was it part of metabolic screen or part of neonatal jaundice screen you did TSH?
We routinely take the newborn screening when they visited us after 72 hours. The basically, remember, the baby could not know the risk factor in this case. So if I plotted on the the neurotoxic risk factor chart. So the cutoff at that time around 60. If you see over here, I will go back to over here. The cutoff is around 17 and we got around 14.2. So it is like less than 3 milligram of the cutoff, because we could not know the blood group and everything. Once we prick, generally we could not wait for the direct antibody test of blood group. Again, we need to prick again for the bilirubin. So at same time,
I understand as a part of, because hypothyroidism gives unconjugated or a conjugated hyperbilirubinemia later than first week. Usually is not the.
No, it is for the physiological jaundice, because the cutoff is around 16.5 and we got a 14. So as per new guideline is within a 3 milligram of the the phototherapy range. So that's the reason. And we could not know what's the mother blood group. If it is, we could not, like for example, baby's mother blood group is A positive, it is not fitted even for the TSB also.
Yeah. Okay.
So what do you, ma'am, Sheila madam? Yeah.
I think neonatal hyperbilirubinemia remains a very common topic to all pediatricians, and proper early screening and charting them. And what the recommendations have been coming is, look at the high risk factor, do a screening before discharge, because early discharges are very common now. Even in C-section, they go home by 48, 72 hours. Feeds not well established becomes an important additive factor for exacerbation of jaundice, and do call them for follow-up. Don't leave it directly to 2 weeks, or this is an important to pick up. In this era, to have bilirubin-induced neuronal damage is not pardonable. And one more thing you remember, G6PD comes as a sudden rise. It never slowly. See, even or your pre-discharge screening can miss G6PD. So if it's a high risk, definitely give parents that before the palms and soles become yellow, they should reach you.
Yeah, thank you, ma'am. I would like to request Dr. Prakash Waghela sir to give the take-up message.
Yeah, just madam has told, we have the routine policy. Each and every newborn, we attending the call, we take the cord blood sample for the blood grouping. If the male child is there, then G6PD and the thyroid screening is there. Because we observe that sometimes the G6PD deficient mother baby will not give. They presented within a 12 to 24 hours of the high bilirubin and the neurological damage is there. So we take the cord sample only. Just if the deficiency is there, if this baby is deficient of the G6PD or thyroid TSH is above the 40, then we ask them to keep the close follow-up. Otherwise, in the private practice, sometimes they will not come to the follow-up. We do not have the close follow-up. And just madam has told, we send the nursing staff to the maternity ward at the 12 and 24 hours to check the transcutaneous bilirubin meter there. And we counseling for them. Otherwise, the gynecologist will discharge the mother within a 12-24 hours. And they came around day 3, day 5, day 7 only. With the hyperbilirubinemia neurotoxicity is there.
Thank you, Dr. Prakash.
Vishal, there is a question in the chat box.
Oh, sorry, I forgot to take. Sorry.
Yeah. Is it medico-legally required to note Bine score in all babies to treat hyperbilirubinemia? I think medico-legally it would, or otherwise also, when the baby comes and if you find Bine score is positive, it's better it's recorded. Because
Yeah, definitely.
we did not have time to discuss the follow-up, AB automated baby R, BERA on follow-up, because only thing which may come abnormal is hearing deficit in some of these babies.
Yeah, so that's a madam rightly said that any baby, I think in our unit, if any baby who require the exchange, we thoroughly follow up for the BERA and the development checkup. So if it is feasible, definitely we should advise the parents and document on your file to beware of the medical legal issue.
There are some more
So
questions probably onto the chat box, so please look at it.
yes, ma'am.
I think Dr. Tilwani has asked exchange transfusion through UVC only. I will probably say if two site, better. UVC,
Yeah,
USC or
yeah.
peripheral.
So we used to do with both line, as rightly said, ma'am. Like one person is removing from the USC and inserting blood from the UVC, but make sure that you need to set the time. Don't do too quickly, otherwise it is not effective exchange transfusion. At least like what we are doing, if it is 5 ml cycle, at least it is 1 to 2 minutes to push that blood and remove that much amount of the blood.
And if possible, traditionally what was done single site UVC, you can do that. You can do through a peripheral radial and a UVC also. So all three are feasible.
Yeah. So there's another question from Manan. Any role of prebiotics or probiotics in newborn with the jaundice? Any idea regarding Dr. Waghela? I think there is no role as I remember.
Yes, there is actually, because whatever happens in first 72 to 96 hours. And to a term baby, I don't see any reason of giving any pre or probiotics.
Yeah.
We are not using even in preterm.
We are not using, yeah.
And
So I would say at least, and I don't think so evidence shows in favor of. If Manan has any study in mind, please put it in chat box.
Yeah, put in the chat box if you have any study. Yes, Dr. Prakash bhai.
Yeah,
Go
choice
ahead.
of the blood while exchange is always confusion in the periphery. Huh?
Okay.
Because the sometimes most of the pediatricians in the peripheral setups, like they will do the exchange transfusion with the whole blood only. They will not get the blood like the or if mother is O negative, the O negative PCV throw in the plasma. So what is your recommendation is there? Can we go for the whole blood, fresh whole blood with extra double volume exchange transfusions?
You could use whole blood, but not more than 72 hours old.
Okay.
Yeah.
Nowadays, the blood banks don't keep it for 72 hours. So then you will have to keep a fresh donor ready. Go for rapid test for HIV, HBsAg, and HCV.
Look for the hematocrit. Yeah.
Yes. Older blood, you will have problem of hyperkalemia and sepsis both. So less than 72 hours old, whole blood. I know periphery would get whole blood only. They will not be able to mix them PCV and FFP or PCV.
FFP, yeah, plasma, yeah.
Right.
So there is a next one more in chat box. If we are doing 2 lines, are we doing a double volume or a single? It is always double volume.
Double volume.
Hyperbilirubinemia.
Is always double volume. Around 160 ml per kg per day. Miss. 160 ml per kg. Yeah.
170. 85 into 2.
85. Yeah. So there's one more question. Any effect of phototherapy on ductus arteriosus size in ELW receiving phototherapy? Again from the Dr. Manan. And does phototherapy increase the chance of HSPDA?
I think yes, you go ahead.
Do we need to use the chest shield in the EW receiving phototherapy? Decrease the chance of HSPD? I don't think so. Do we have any proper trial on that one? I'm not aware.
No. At least there is no shield advice for that.
Yeah.
Yeah, it does increase persistence of duct. But again, remember, the PDA, a small ELBW has multiple risk factors for PDA to remain open. So it's only phototherapy may not be the reason.
I
And
think I would like
using a chest shield will also decrease the surface area.
Area, yes.
Yeah, definitely. So you will end up with the accent transfusion unnecessary.
Yeah, definitely.
So Dr. Mana, if you are on the online, could you address on this one? Do you have any study on this one? So we'd like to interest, if it is like affect the PDA with the phototherapy, because we are struggling with the PDA all the time in the preterm baby.
Maybe we started doing a lot of echo. We are over also reacting also.
Yes, Dr. Manan.
So as Madam told that PDA is very multi-dimensional and multifactorial disease. But the recent meta-analysis what it says that shielding the chest will help to reduce hemodynamically significant PDA which needs treatment in the form of medication. So uh, and this it is said with the caution notion that the further studies are required, but we have to be careful in ELBW while giving phototherapy. So
It is just, it does
Yes.
it for the prevention or it is for the treatment?
it is for the prevention. Yes, prevention.
Prevention, okay. Okay.
Yeah.
So it might not make a hemodynamically stable one a significant one. If
Yes.
probably.
Yeah.
Yes.
And at last, Dr. Pooja, do you want to add something on top of that one? Take home
No,
message.
ma'am has covered almost everything. Just one take home message would be since nowadays TCB is available in most of the NICU setup, then at least before discharge, if you are discharging early, because nowadays parents are not ready to stay in the hospital for a longer duration. Even LSCS mother is getting discharged on day 2 or day 3. So my advice would be at least before discharge, if they're not ready for total serum bilirubin, one should get done TCB of that child and use our specific for normogram and need to stringently follow the discharge policies.
I think Pooja, I agree. In a public hospital with large load, we are using
Yeah,
TCB
ma'am.
only on discharge.
Yeah, it's not possible to, ma'am, take total serum bilirubin
For
value of
everybody.
all the
And
babies.
we are not onto that metabolic screen program. Otherwise, at 72 hours, we could have done with that.
Yeah.
Yeah.
There's
So
one
there's
more. Okay, yes, go ahead, ma'am.
Persistence of jaundice beyond 7 days in a breastfed baby is common. So don't jump to the thing that this is abnormal persistence. You need to keep them on follow-up. I would say
Yeah.
beyond 14 days would be something which is alarming. And when you are using beyond 7 days TCB, there is, a caution, because
Yeah.
in becoming more mature, your TCB values may not be standardized.
I want to add one more thing regarding this new guideline. If you see the chart, in the no risk factor, you can see the chart up to 40 weeks to 35 weeks. Am I right? And when you see the risk factor, they put a risk factor like less than 38 weeks. So why they put that gestational age on that chart? That's also I could not,
Late
understand.
preterm, late early term and late preterm
No,
have
but so that means any baby who is less than 30, we have to follow following the neurotoxic risk factor chart. Am I right? They haven't mentioned that. They haven't. Yeah, they haven't
there are two
clarified.
things. Vishal, there are two things. One is that compared to the previous normogram of 2004, they have elevated threshold. So when they have elevated threshold, they want late terms to be included in that, while late preterm and early term, they don't want to elevate the threshold levels.
Yeah. So if you see, this is a phototherapy for neurotoxic risk factor one,
Yes.
more than 38 weeks and something. And if you see the risk factor list, they put less than 38 weeks, So why
Because
we do
now,
have a different chart then?
No,
For the
because
less than
now they have
28.
put as 39 weeks, 38 plus 6 weeks as really term. These are
Ma'am,
early terms.
this one is a phototherapy therapy, no risk factor one. If you see like 38 weeks, they put the full line, the red, blue, and this one. But if you see the risk factor over here for the neurotoxicity, you can see there's a gestation is less than 38 weeks. So
This
my
is
question
fine.
is,
Yeah, your point is right, Vishal.
yeah.
But it has come, if you review the late premature and early term, relatively your incidence of jaundice has been little higher, and the feeding related issues are also more. So maybe you might come in phototherapy zone a little
Yeah, so
higher.
so by default, if less than 38 weeks, we need to follow that chart, you know, risk factor one. Am I
Yeah,
right?
but then you
Yeah.
can use your clinical judgment a little bit.
Yeah.
And because in our condition, sometimes exact weeks of gestation are also not known. Or you have babies who are SFD, who are polycythemic. So those things in this criteria, the SFD and polycythemia are not looked at it at all.
Yeah. So now I would, before I end up this session, I would like to request Dr. Swetal Madam and the Kunal Aya to, if they want to add anything on top of that or any few words regarding the hyperbilirubinemia.
No, the final word is from Dr. Sheila, madam, and she is teacher of teachers. So there are so many practical tips which we were hearing day in and out in our department she has already shared, and in fact it is like she has imbibed in our mind certain tips like look at the anemia component, don't miss out the on discharge screening with TCB. So wonderful session. Thank you so much, all the panelists. Thank you, Pooja. Thank you, Prakash bhai. Thank you so much.
Thank you so much. And always I just, debate when I talk with Arpan. I was the only person who is from the pass out from the VS, and sometimes I feel that I have to be in the Baroda, to train under Dr. Sheila Madam. But unfortunately, I was unlucky over there. Thank you so much.
Okay, my pleasure.
Thank you.
love
Thank you,
you.
Vishal. Thank you, madam.
Thank you, Pooja. Thank you, Prakash bhai.
Thank you.
Thank you. Bye.
Thank you, all the panelists. Thank you, moderator Dr. Vishal. Thank you so much, Sheila ma'am, for guiding us through this panel, and it was an excellent talk. Thank you so much, Dr. Pooja and Dr. Prakash, for taking the session and being the panelist. Such an excellent. I would like to thank Shwetal ma'am for invite Dr. Vaibhav also to be there till the end.
We should thank Dr. Tilwani and Dr. Manan for making
Manan,
it more
yeah,
interesting.
interesting.
We'll definitely come up with these studies later on in the future sessions.
Yeah, sure.
Thank you so much.
Thank you. Thank you.
All right. Thank you so much, everyone. Thank you for the wonderful cooperations. Hoping to meet you again on this platform very soon for any other next sessions. So with all the due permissions, we are concluding the session over here. Thank you.
Thank you.
Take care, everyone. Thank you.
Bye.